Good afternoon, everyone, and welcome to the second session in our webinar series, COVID-19 Forum, How Coronavirus is Reshaping the Future of Home Health and Hospice. Before we get started, I'd like to go over just a few items so you know how to participate in today's event. You're listening to today's discussion using your computer speaker system by default. If you would prefer to join over the phone, just select telephone in the audio pane, and the dial-in information will be displayed. You can submit questions to today's panelists by typing them into the questions pane of the control panel. While we anticipate taking the entire hour to cover today's topic, we will address your questions in a document following the webinar series, as well as share today's webinar recording. This webinar series is brought to you by Healthcare at Home, the Rowan Technology Report, and HealthRev Partners. Published by Home Care Technology Consultant and today's moderator, Tim Rowan, the Rowan Report is the most authoritative and respected technology news source in home health care, gathering, delivering, and interpreting news about home care technology, regulations, marketing, and other important issues. HealthRev Partners is a revenue cycle management company that takes a tech-driven consultative approach to coding and billing, producing measurably higher results without the higher costs. We deliver tailor-made RCM solutions that address each of our clients' specific goals and challenges, providing detailed insight into operations and performance. Now let's get started. Not only is the home care industry under tremendous clinical pressure, but you're also likely feeling a financial squeeze. And because of this, forward-thinking agency leaders are seeking out new strategies and opportunities to remain solvent. In today's discussion, our panelists will chat about ways to achieve financial success when so many are struggling. So I'd like to go ahead and introduce to you today's panel. Bobby Robertson is president of Missouri Home Hospice, a company that actively invests in out-of-hospital care, including the recent acquisitions of 5 home health and hospice providers within the last year. He has more than 20 years of experience in home care, providing strategic leadership on both the vendor and provider side. Chip Carroll is the Director of Strategy and Business Development at Playmaker Health. He has more than 14 years of operations and business development leadership experience in the post-acute care industry. Most recently, Chip has worked on the technology side of the industry, bringing firsthand knowledge and experience into understanding how technology can impact agency success. Also with Playmaker Health, we have Holly Miller, Chief Revenue Officer. Holly is a 15-year healthcare and technology sales and marketing expert, contributing to Playmaker Health's strategic growth initiatives. She oversees the partner program and leads the sales and marketing team. Next up, we have John Reisinger, CPA. He is the principal of Innovative Financial Solutions for Home Health. He's a financial consultant that works with owners, operators, and staff of home health care agencies to help them become more efficient and improve their bottom line. And last but not least is our very own Rachel Bracken, Vice President of Services for HealthRev Partners. With more than 10 years of experience in home care, she's held many roles, including office administration, coding and OASIS review, and branch management. In her current role at HealthRev Partners, Rachel oversees the planning and delivery of our coding and billing services, as well as customer success. And we are so happy to have Tim Rowan as the moderator for this webinar series. Tim is a nationally known home health care consultant and the publisher of Home Care Technology, the Rowan Report, which has become the industry's most widely read journal covering technology and regulatory issues for home care providers. With all of that being said, I'd like to go ahead and turn the discussion over to Tim.
Thank you very much, Megan, and thanks to all of you for joining us today. I feel a little intimidated in the presence of this prestigious panel, but I think that the best thing for me to do is to ask a couple of questions, sit back and be quiet, and let the experts speak. So we're going to be talking about the financial implications of the recent events and the intersection of a totally new payment policy from CMS, along with a crisis that's unexpectedly hit the country. And I think these folks are extremely well qualified to teach you about it. Can I start with you, Bobby? You're the one today who is working in an agency. I understand both home health and hospice. So Tell me what you have learned with the changes CMS has offered to help us cope with COVID-19. Some of the flexibilities, especially if you could speak about the flexibilities with regard to remote patient monitoring. I know that they have encouraged its use because people don't want to be in each other's presence. But as we know, encouraging is kind of a heart thing, not a wallet thing, with the way CMS is wanting us to use telehealth. So what do you think? What have you been learning about the use of telehealth, the lack of reimbursement, and have you in your agencies, both home health and hospice, changed the way you're using it so far?
Sure. Yeah, so first of all, yes, it's been a crazy, crazy year, as we all know. And, and we've had to look at every part of our operations and have made changes to just about all of them. Just keeping up with the waivers has been almost a daily job. We've got somebody in the office that is participating in so many webinars on the phone with the state, with CMS, to make sure that we're doing the right thing. And it's been good to see that they've allowed us to change our operating methods. As it relates to telehealth, we're using telehealth for some of the traditional benefits, trying to do appropriate visits versus just planned visits. But what we found during this COVID period, we found telehealth to be a very useful tool in managing fear. Because when you boil all of this down, there's a lot of fear from the physicians about, should they discharge these patients from the hospital? Are they doing it too early? Is it right time? The patients and the families are very fearful of, am I in the right care setting? I'm at home. Should I be in the hospital? And that fear creates a lot of rehospitalizations and everything else. And with us being able to communicate with them and engage them on a daily basis to make sure they know that they're at the appropriate place, getting the appropriate care, just managing that fear, I think, has been, something that I didn't really think about as a benefit of telehealth, but it's proven to be a very valuable tool for that alone.
It's not been that long, technically, although it seems like it's been years since the virus hit us, but have you seen any changes in hospital readmissions and patient acceptance and things like that?
Well, we actually improved our rehospitalization rates during this period. And I think it's because we, in a lot of times, in a lot of situations, especially in hospice, we were locked out of facilities where we're seeing a lot of patients. And so we had to deploy a lot of, tech, with telehealth and other communication means. We had to deploy a lot of other strategies to get access. So yeah, it's changed a lot, but we think that we've improved our operations tremendously as a result of the force of change behavior or behavioral change in our industry. So it's been a good thing for us, actually.
I want to keep talking about telehealth just for a second before we move on to some other things. Rachel, you have a number of clients, and I'm sure, same with John. Rachel and John are the consultants among us. And John, I know you keep as close an eye on what CMS is doing and might yet do than anybody. So I want you to listen to this question too, John. But Rachel, what are your clients telling you about the use of telehealth without reimbursement?
I think they're all very, very hopeful about it, and they found the great value in it. Obviously, we hope for them to be reimbursed for the use of telehealth very soon. I feel that they deserve to be reimbursed for all the services that they provide. And luckily, we have NOC and similar advocates just advocating for us on a daily basis to get these visits paid for, so that we're not having to endure the amount of LUPAs that we had seen prior to COVID, during COVID.
John Reisinger, you have a number of clients. You have a lot of clients, and they're all Medicare based, and you've been watching since PDGM right before we even knew the word COVID-19 about lupus. You've been watching about the pros and cons of virtual visits with regard to increasing the number or decreasing the number of lupus. What kind of advice have you been giving your people?
Well, one of the things that we've all been having to deal with in home health in particular with telehealth is that historically it has been a non-reimbursable cost, okay, which meant that we could do it, we could provide the service, it was an allowable activity, but there was the cost was treated as a non-reimbursable cost. So not only did you lose that cost, you lost a portion of the overhead that got allocated down to it. So it was a double whammy to provide benefits to the patient, Medicare or not, which never really made sense. So agencies have historically been reticent to make a significant expenditure into home health because of the cost that it was to the agency, even though it's been documented for decades, the benefit that it can provide to the patient. The one thing that's come out in the proposed rule that CMS published at the end of last month, at the end of June, is, and this is for the home health reimbursement for calendar year 2021, is that they are making, it's a significant move. It's just not what I think is significant enough. What we in the industry will think is significant enough is they at least are now proposing to allow telehealth costs to be treated as an allowable cost. Okay, it's not a reimbursable cost, but it is an allowable cost, meaning we can include it up in the A&G area, and then those costs can get allocated out to the various disciplines. So Medicare would pick up a portion of those costs. Everybody that I've talked to is very jazzed about this. They're very excited about this because, again, having any type of remuneration from the government has always been the biggest stumbling block to telehealth because it's not a cheap endeavor to get into. So, but everybody has a positive feeling in it right now. But I would also push that a little further, that because the proposed rule is in the rulemaking process right now, we get 60 days from when the rule is first published to be able to submit comments. All stakeholders and interested parties are able to submit comments. One of the things I'm telling all my clients, and I'm putting out, I have it on my blog, take a look at my blog that I have about the proposed rule. My website's ifsforhomehealth.com. And it talks a little bit about the rulemaking process and our ability to submit comments. And one of the comments I'm recommending that everybody make, because I think this is one we need in the thousands. We need thousands where people submit a comment and say, we would like to have telehealth visits, remote monitoring visits, be treated equal to that of the doctors, the hospitals, and the outpatient therapy clinics that get those treated as allowable visits. Okay, it may be a big push to try and get this year, but it definitely puts CMS on notice. They're not going to do a blanket statement. They're not going to allow all therapy, all telehealth visits. That's never going to happen. But they may do it within certain parameters that they do allow that, which would be a huge step in our direction.
You know, it still comes down to whether or not CMS trusts us or not. The last time I spoke with Bill Dombey, he said that CMS told him, well, what if they use a telehealth visit to cross the LUPA threshold? We're not going to pay $1,500 for one virtual visit. And that's the attitude that we have to, that's the uphill climb that we have to get. But what about referrals? Holly and Chip, you are dealing with people all the time from the CRM aspect, and you're training salespeople on what they should be saying to referral sources. I'm curious with regard to the whole telehealth question. Have either of you heard, I don't care who goes first, but have either of you heard that having the ability to do remote patient monitoring is a plus in the sales conversation.
I'll jump in. We absolutely are hearing this from our clients on a regular basis, and all leading indicators show that we hope and we pray that this will be passed and it will be reimbursed as it should be. I think from a compliance standpoint and the ability to effectively treat and manage their patients, we're going to have to do something here. And so we are having these ongoing conversations with our customers and our agencies on a daily basis. Chip, you and I talked about this earlier. I don't know if you want to add anything else to it in terms of what CMS has done thus far.
Well, I think that if you look at, there's 85 new telehealth service technologies that are being looked at. And so that's, again, I think that's telling as to where we're at with that. And our clients obviously are reciprocating that information back to us as we have contact with them through support, or whether it's integration or just engagement. But I definitely see that as a positive. And it's also a selling feature, if you will, in the industry. If you're providing that type of technology, that means a lot, especially while we're during this pandemic, if you will.
And Tim, I'll add one more thing. When all of this hit, we talked to a lot of our agencies, and the conversation was, how can we help? What can we do? And more agencies said, we have a ton of referrals. We just can't go in and see them. Either the families and the patients don't want us to come in, or the caregivers don't want to come in. We've got to get some telehealth approvals going on right now. It's going to be key to the outcomes of our patients, readmission rates to the hospitals, et cetera. So it's something that from day one was top of mind for everyone, and that they were coming to us and saying, do you have any information? Do you have tools that can help us, et cetera?
That brings up so many other questions. I want to see if we can run at them one at a time. Coding and billing and PPE and the refusal of patients to let anybody in their door. Bobby, what are your clinicians telling you in home care and hospice about, well, first of all, what are they telling you about the coding challenges, and especially if they can't get in the house?
Yeah, the access to patients has been a real thing. And I think any providers that you talk to will talk to the fact that their looper rates have gone up because of that. It's been a scheduling nightmare. So when COVID first hit and patients started becoming aware of how significant this pandemic was, the fear just grasped them. And we had a very, very high incident of canceled visits, turning us away. We had to deploy a lot of tactics to ease that fear, to be able to make them understand why we needed to be in there helping them, and we've improved it, but it's still an issue.
Have you had COVID positive patients?
Yes, yeah, we have been. There are some providers in our area that are not taking COVID patients. We are. And we have all along. We've tried to, we've done everything absolutely per the CMS and our state guidelines on PPE and all of the appropriate measures around that. But we spent a lot of time with a few individuals, a few of our caregivers that take on the bulk of those cases. But we tried to do the right thing there.
This must present some challenges to your billing. Rachel, you help clients with billing, don't you? What kinds of dilemmas have you seen them? And John, get ready. I'm going to ask you the same question. What kinds of dilemmas have you seen presented because of PDGM and COVID all at once?
Yeah, I mean, that's a great question. I think so that was a point that I was actually going to bring up. We just think we're getting a handle or a grasp on PDGM, and then we're, just out of the first quarter, here comes COVID to sweep us off our feet again. So obviously it's been a never-ending battle, or it's felt like a never-ending battle. But we're in home care and hospice, so let's be honest, we wouldn't be in this industry, or we wouldn't make it very long unless we can adapt to change. So I think that's one thing that home health and hospice agencies are great at, and just being able to be there for our clients and support them through the struggles and just keep up to date with the new compliance rules and regulations that are coming out constantly, and ensuring that they're not going to have any monies pulled back from them once everything settles down, to ensure that they're still doing everything correctly right now during this whole shakeup.
John, I want you to tell me about the kind of advice you're giving clients about billing, but first I want to let Holly and Chip and Bobby know that I also want to hear from you next about losing. Is Rachel right? Are home health agencies adapting, or has Playmaker been losing customers because they've just been disappearing? And Bobby, have you been acquiring new agencies because they're suffering and they're desperate to get out? So while you're thinking about that, John, what about what Rachel just said about billing?
Well, I would echo what Rachel has just said, that, that it's the challenges with PDGM, going into PDGM, were monumental enough. And then, in late March, then this pandemic hits, and it's really created a perfect storm, so to speak, that's really complicated things. And I've seen both ends of the spectrum. I've seen agencies that have just been devastated because everything's happening at once, and they haven't been able to really get a handle on how to process their billings. But I've also seen agencies that have, because of the pandemic, it's really helped them accelerate their billing practices and their ability to, go from admission, from the start of care to the wrap, to getting that final claim out, that they've really accelerated, they've really fine-tuned it, which to me gives those agencies that have done that a real advantage going forward. And there's something else that everybody needs to be cognizant of going forward, and this is again in the proposed rule, but it was also proposed a year ago when they were preparing us for PDGM, is that starting on January 2021, the next year, that the new all 30-day payment periods, we're going to be going to a what's called a no pay wrap as opposed to a wrap. Okay, the no pay wrap is just what it means. There's not going to be any payment. We're not going to get 20% of the episodic payment anymore with that. And on top of that, if that wasn't financially difficult enough, CMS has also stipulated that starting on January 1, 2021, any and all 30-day periods that aren't billed by before, the no pay wrap is not submitted by before day 5 of that 30-day period, will face a financial penalty, means a reduction in their episodic payment. In that episodic payment, the calculation is going to be, the denominator is 30 because that's how many days there are in the 30-day episode. The numerator is the day number of the period that you are in when you are submitting the wrap. So if you submit it on days 1 through 5, no penalty. Okay, but if you submit it on day 6, which is just one day after the 1 through 5 range, okay, you submit it on day 6, the numerator is 6, the denominator is 30, that's 20%. You're looking at a 20% reduction in your episodic payment for that episode. And if you submit it on day 30 or after, you lose all payment.
That's a little frightening.
Yeah, so people really need to be on top of their billing starting now, because you don't want to be trying to fix that come next year.
Well, the implications go back to what we were talking about with the other group 2 weeks ago. It becomes an onus on the OASIS nurses to move that OASIS assessment through as quickly as possible. We've always had, ever since the beginning of PPS, we've had that relationship between clinical
and the coding aspect of it, because a lot of people outsource their coding, which is fine, but everything has to happen so you can get that no pay wrap out within that first 5 days.
They're going to put some pressure on Health Rev Partners, Rachel?
You know, I feel like we're prepared for it, and it's actually an incentive to outsource, but you have to have the right outsource partner, because I think some of the vendors out there are not as prepared as we are. The thing that I'm fearful of is possibly losing out on the therapy evals by trying to push those OASISes too far up. So, you know, a lot of times we are holding them up until the 5th day just to see if the therapist is going to go out so that they can collaborate on those M items, especially the 1800s. Functional M items, it's so important under PDGM to make sure that those are correct. And, you know, I will strongly encourage our customers to try to get those therapy visits done as quickly as possible, even the day after the start of care, so that we can get started on the coding and the OASIS review and get the wraps out there. Because we do both coding and billing, I think we have an advantage there, because we're going to be able to notify our billers as soon as the OASIS is done and ready to go, and they can drop that wrap and they can get it out there within the first 5 days. So that'll be a seamless transition right there. So I think we have an advantage over some in the market.
Well, unless the industry's comments have any effect, it's going to happen and come January. Holly, you are involved with selling to salespeople, and so you probably know better than anybody what's going on with that question I was asking before. What Rachel said about the resilience of home health.
Yeah.
Some of the EMR vendors tell me they've been losing customers. How about Playmaker?
You know, I will tell you, Tim, when this first started and everything hit, we had already started the year out thinking that we were likely going to lose customers due to PDGM, whether it's through mergers and acquisitions or people closing their doors, et cetera. So we already had that mindset. And so when the pandemic hit, we pulled together and it was what's really going to happen? And we were bracing for the worst. And honestly, early on, we had a few customers call in and ask for some deferment in billings. We had a few people want to drop some of the services and license it and not get rid of it. But then we saw a gradual shift of people actually calling in saying, you know what, I've either had to furlough some of my marketers and liaisons. I need the technology and the data even more now, so I'm going to have to accomplish more with less. Or I have fewer reps out in the field. I need to make sure they have every tool necessary to be successful during this time, whether they're making virtual calls or they're going through data to identify the highest and best referral sources, or is it an opportune time to take out a competitor, or conversations we've had with people. But so that's one aspect of it. So I think we braced ourselves to lose clients. We had a slowdown in terms of give us some grace, which has picked back up. We've actually seen growth. We're actually having new clients come in and say, we knew we needed technology in the past. We tried to put it on hold. We now know more than ever that we're going to have to, monitor and measure remote workforces and be able to look at their productivity, their efficiency, and guide them through this as they are doing more virtual calls. We're going to need the data now more than ever. So we've not seen the lull that I think we expected to see. In fact, quite the opposite in terms of new clients. Our existing clients have actually had the time now to pause. We've done a lot of retrainings. We've done a lot of deep dive training. The workforces have been home and they've had the time to really dive in deep to the application and make sure they're using it effectively, and that they're ready as they come out of COVID and they have the tools and they're ready to hit go and play. So it's been a great time for us to connect with our clients, make sure that they know how to use the application, give them enforcement training, help them navigate this. So while we saw an early downtick, things have stabilized and actually started to be on the upside.
Chip, you have a completely different role there at Playmaker. You have been training and supporting clients. Have you seen the same kinds of things Holly has?
Yeah, well, you know, I was part of the CMS Roadshow with PDGM last year, and I kicked it off in Florida. I was there, And what we knew them from the EMR platform, our partners, obviously, as we integrate with any EMR platform, we knew then that they had to prepare for PDGM as well, for the compliance and regulatory piece, but also the billing piece. And so when you start looking at the billing and coding needs and that change, the impact that PDGM is having, the early to late referrals, all that ties into data. And so it's a perfect time. Even then, I kept saying, and we all echoed the same thing, you really need to evaluate your EMR partnerships to make sure they're prepared and ready. And I think, as Rachel alluded to previously, is that I think your partnerships right now, especially in the technology space, means everything. Because again, you're able to do more with less if you have the right information, and you're able to actually train people and show them that it will enable you to actually do better patient care because you're more efficient and effective in the way you're approaching your daily activities. And so we want to pass that on. And again, when engaged with existing client bases and working with our partnerships, even with the associations would tell you they had a dip in memberships at the first of the year with most of the associations of those closing doors, not prepared. And we're specifically talking more on the home health care side for PDGM readiness. They just weren't ready. So they decided that, we're going to close doors and move on or acquire. But they've also seen a leveling, and then they've seen new memberships coming on board throughout the year. And then COVID hit, and things really changed. So I think echoing a little bit of what Rachel said and tagging on to what Holly mentioned, it's a great time really now to make sure that your technical relationships and partnerships are solid. You're my partners being a true partner and engaging with you to make sure there's compliancy. And looking at, for outsourcing your billing and the coding, to Rachel's point, a lot of times when you negotiated that margin so low, you kind of get what you pay for. So when you had this change, the platforms maybe could support that, and now you may be reaping that. And so again, I think and we'll migrate to this as we go along. But again, I think the information, the technology space is more relevant now than it ever has been. So being able to navigate and manage that is so important right now in every aspect of an agency.
Well, that brings us back to the provider with his boots on the ground. You told us about the way your group has been expanding with acquisitions. Is that because some of the agencies around you are suffering?
Yeah, I think so, Tim. There was a lot of fear, clearly, of PDGM moving into this year. So there were a lot of people that were positioning for that anyway. But when we had all of these other things happen, with COVID in particular, that accelerated some plans, but because they just didn't know how to handle it. I was on the technology side of this industry for a long time, and we preached to everybody for years and making sure that they were working with their vendors in partnership and using the latest technologies to layer technology into the provision of their services. And I have never felt as committed to that as I do right now, because I lived it this year. Thank goodness that we made those investments the end of last year to move everything to web-based technologies, even our phone systems. We were able to move our switchboard on a day's notice to somebody's home because we've got a web-based switchboard and handle calls for multiple organizations or multiple of our providers. We have outsourced services that we utilize, which was a huge advantage versus a biller being in our office, going home because of fear of COVID. Maybe they had a higher risk, they're in a higher risk category. So we avoided all of those things. And then rolling back to the acquisition question, we were ready. And so I guess the fear of everything going on with PDGM and COVID and everything else put the agencies that we've acquired on, and one that we closed April 1. So in the thick of COVID, it happened so much faster because they weren't ready for all of this, and we were able to layer in our processes almost immediately and make a difference. So yeah, it's the readiness was key to this thing. And again, that was partnering with vendors. We used the time to even renegotiate our contracts, not all of them down in cost, some of them up in services to get a better result and to navigate this whole thing better.
So that's what you have done so far, Bobby. But how many of those changes that you made for both PDGM and then quickly when the pandemic hit, How many of those do you think are good changes that you'll keep?
All of them. I mean, we've done nothing that I would pull the reins back on right now. You know, we hope that we get to a point to where we don't have to be as vigilant as we are around, you know, certain things, infection control and everything else. You know, we're hypersensitive to that now, of course, but I believe it's sort of a way of life going forward. I think our world has changed, and we have to be ready for it. So, you know, I'm very, you know, I'm very grateful that we took those hard tasks and projects on with all of the, you know, change behavior that comes with that and all the difficulties in switching systems. But we did all of that, and it was finished up just prior to COVID. And thank goodness, like I said before. But I too want to make sure that, you know, we don't. I'm not going back on any of those changes, but I feel like we're just so much more capable, so much more efficient, and it happens so much faster because of this too. I mean, it's a horrible thing, right, that's happened. But I believe as an industry, on the provider side, we're much more prepared to deal with pandemics like this.
Pandemics like this, which happen every 100 years, or who knows, might happen again, and who knows when this one will go away.
Yeah,
it's not looking good right now. But you talk about the changes that you made, and there are challenges that result in lower reimbursement, both from the pandemic and PDGM. But so often people think in terms of, well, let's cut back here, let's cut back there, let's streamline and save some money. But what have you done, if anything, with your lengthy technology background to invest in order to save? What kinds of technologies, if any, have you bought that will in the long run prepare you to get by with lower reimbursement?
Sure. Well, a lot of it, you know, was streamlining things across multiple providers, right? So we've got one process for whatever, you know, that operational task or caregiving task is. We use one EMR across all of them. You know, as you know, Tim, I'm a huge advocate for web-based technologies, always have been, and that has proven to be very valuable. The web-based phone systems, telehealth, our use of telehealth was very, very immature before, and I believe we're very mature with it now and in how we use it. Gosh, I'm trying to think of what else we've done, but just, you know, so much has happened with us because all of these providers I brought on into our company over the course of the last year. So this was not just COVID change. We were doing major changes before this, and you know, when we got into April, when things were at for us, the low point as far as census and everything else, I had staff that was complaining about the change and all of the change we were doing prior to that were thanking us. They were able to work remotely. They were able to get their jobs done from wherever they were, home or office, or even at relatives when they were helping out. And so we were just so much more capable as a result. And I can't see going backwards on that. The things that we also invest on, we stepped on the gas from a marketing standpoint. I believe that home care has proven we are a valuable, valuable piece of healthcare right now, more so than any other, you know, form of healthcare delivery. You know, we're ground zero, and we started running TV ads in the middle of this, pitching the safe at home. You know, sometimes, you know, the safest place to be is at home, and we definitely, as providers, can provide that needed care at home. We invested in additional marketing reps, even though marketing now is not traditional, you know, and asking for referrals and trying to build those relationships like that. We were, you know, going out and seeing where we can, how we could be a resource to them, and had the conversations about, look, we all could have handled this better in March and April, but we've learned so much. Let's sit down and have a conversation about if this thing rears its head in a significant way, again, how are we going to handle it this time? And I think they've really appreciated those conversations. And I think it's elevating our significance in healthcare delivery across the country.
Thanks, Bob. John, you're dealing with the same thing across multiple clients that Bobby is dealing with within his organization. You're trying to figure out, let me put it this way. In your career, I know you have always tried to help people to understand how to get the maximum amount that Medicare wants to give them. And now that's tough because Medicare wants to give them less, and the things that you might cut could be more harmful than helpful. So while you're thinking about your answer to what have you been advising your clients, I need to point something out. You have described in 2021 a thing called the no pay rep. You realize that what you're saying is that is the no payment request for advance or anticipated payment. No payment request for anticipated payment. You would relate to this best, John. Somebody recently pointed out to me that when the Angels changed their name from Anaheim to Los Angeles, if you translate it, it goes the Angels. Oh,
Yeah.
I want to see if you can help it. Tell us what you've been advising your clients with regard to lower payments and operational efficiencies.
Okay. Now, to digress a moment about your point about the no pay RAP, and the RAP is request for accelerated payment. That is just going to be termed that for 2021. In 2022, they're going to change the terminology to a notice of admission, an NOA, something similar like the NOE, the notice of election in the hospice. Okay. Now, as far as what I've been advising my clients, first, as a financial consultant, I will say that I don't do coding, I don't do billing. Okay, those are two aspects that I work with people to do that, but I don't do it. That's not where my area of expertise is. I'm the behind the scenes in the office looking to see how to become, and this is the key, the most cost effective and financially efficient that you can be. Right there, that is what all agencies need to learn how to do, bar anything else from a financial operations perspective. The worst thing I see, and I'm sorry?
In other words, making sure that the OASIS asks for enough money for the plan of care.
That's part of the process, yes. So, because one of the worst things I ever see is what you were describing about how do we deal with lower reimbursement. Well, let's cut costs. And then you see people go down their trial balance, their chart of accounts, and say, well, we're going to reduce cost here, we're going to reduce cost here, we're going to reduce cost here. You have to understand the relationship of all your revenues and all your costs. Okay, you don't understand the relationships that exist. You end up cutting something, you end up spiting your own self. Okay, that's where, from my perspective, okay, with what agencies really should be doing from a financial analytical perspective, COVID hasn't changed a thing. I mean, people should be doing today what they should have been doing 20 years ago, okay? It's just the vast majority of them don't do it, okay? Because either they don't have experience doing it, they don't know that they should be doing it, they haven't needed to do it in the past, but then again, the first 10 years under original PPS, CMS was so grossly overpaying us, all you had to do was open up your doors and you're going to make a profit. Okay. As they've been cutting the costs over the last 10 years, this is where you really needed to be, learn how to be cost effective, financially efficient. So that's what I've been trying to lead my clients to. And it's not just on the financial side. As you alluded to, this whole thing, we're in home health. I'm not sure if it was Rachel that said this earlier. We are in home health. I'm a financial person, but I'm working in home health. And I understand the whole basis of what I do is providing care to the patient. That is what we do. I'm a CPA, I'm a numbers guy, so I live in that world. But I understand that everything has to be done in line to be able to provide the best care possible to the patient. And with Medicare, which we're primarily talking about, that starts with the OASIS. And the way that you really try to work on that, one of the things I've been trying to talk to clients for years to do is everybody has a DON, okay? A nurse that's basically an administrative individual that's in the office that manages everything from a overall perspective. I've been trying to talk agencies into having a therapist, either a PT or an OT, in the exact same position, okay, to help accelerate and to be able to manage internally, especially if you use a lot of outsourced therapy services, okay, because historically outpatient therapy services have sort of been looking out for themselves. You know, they've been, if they could do 2 visits or they're going to do 10 visits for the patient, well, they're going to do 10 because they're going to get paid more. Okay. So an internal therapist at that level would say, no, 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 let's ratchet this back to a more reasonable amount. And that's where I think that agencies need to be, because what you want to do, okay, you have these 2 big documents that really drive everything. One is the OASIS. The OASIS is what dictates what your revenue is going to be. So you want that to be accurate to the nth degree. And then from that OASIS, you develop the plan of care. In the plan of care, well, most people don't really tie it together, but the plan of care actually identifies what your cost to provide that level of care is going to be. There's no cost associated with it, but if you do the proper financial and operational analyses on a monthly basis, you can project what that cost is going to be. And the stronger, one of my big point is, the stronger you make that correlation between the OASIS and the plan of care, better off you're going to be. Doesn't mean you're going to make a profit on every episode, but in the big picture, you're going to be much better off.
Another reason for having a dialogue between financial and clinical, ongoing and intense and frank.
Yeah.
And the most successful agencies have that door open 24 hours a day.
That's right. And the ones where they don't have it open are the ones that get into trouble.
They're the ones that Bobby's looking at and saying they're our next candidate.
Well, it's interesting you say that, John. We've got a therapy manager too, and I can't tell you how valuable that was through this PDGM effort. It's been an incredible add to our team.
Especially with the major changes PDGM brought to the way we use therapy.
Certainly.
But, you know, I have to make one other point. It's not just the accuracy of the OASIS, it's the timeliness as well, right, John?
Without a doubt. Let's not forget 5 days. You know, the regs say you have 5 days to lock it down. Well, that doesn't necessarily do you a lot of good if you're locking it down at the 11th hour of the 5th day and you still got to get that wrap out. Okay, now the no pay wrap is going to have less documentation requirements associated with it because there's no cash coming to you, but you still have to get it out on time.
Right. So Chip, you have to be in a position where you also are advising your Playmaker Health clients about changes. But what I'd like you to help us with is the clients that you deal with, and I'd like maybe all of you to weigh in on this. What are the biggest challenges that have been presented? And at the same time, have there been success stories, and what brought those successes about?
Well, I can't really speak to the clinical piece of it with what we do. It's more the analytical piece of it. But I do think that when engaged with clients and looking at the effort that's been put in to address patient need, responding in a timely manner, you know, it's leaning back to the technology piece for the most part. Most of the issue is around transparency. It's around focus. It's around the ability to actually live up to the expectation that you've already set for the patient and the family members. And I think, you know, going forward and moving forward, we're going to see a lot more of that. But I think with the technologies, and again, I keep saying technology, but I think as we're able to really lean into, as Bobby said, they were already doing this and harnessing this. And in my career span, you know, I lean towards the technology partnerships to help me engage, stay engaged. I can't know everything about everything, but if I have good information that's easy to access and use, that allows me to be proactive and not reactive, especially in this environment, it's going to make us more successful in the long term. The existing client base with Playmaker obviously is around the strategic growth strategies. And so as you're looking at, you know, it's, you know, how do we become relevant, or how do we stay competitive in a market to where maybe we didn't have the market share? Well, at least by having the data available to them, they're able to hone in on what exactly it is they need to be doing. And it's helping become a resource. And I'm not sure who said this, but I totally agree. once you're a resource to your referral base or your partners, there's a trust element. And we all know in home health and hospice, especially hospice, there is a trust element that's developed from that. And so even though we are a technology provider for data, for growth strategies, we are more also trying to engage and re-engage in client base to say, there is an expectation of our solution that it can provide you a lot of good information in real time that allows you to be successful, have the focused areas that you maybe are struggling with, especially as we're going virtual. So although I'm cross-pollinating a lot of areas, just speaking on the experience, and obviously others can chime in, but just from my experience currently, that's kind of what I've seen, and that's kind of what we will continue to kind of hone in is we have a great base of partners, not so much clients, and how do we make those partners understand the value proposition and also how they can stay relevant within their market. Because again, it's different times, and technology for us in our space is really helping them connect to purpose of why they're doing it, how they're doing it, and really focusing on what makes them different and unique.
Holly, I assume you've got the same perspective as Chip, but can you think of the number one challenge facing your clients? I'm sorry, your partners?
Yeah, I would say Chip nailed it, but it's also what's been great about all of this. Well, we may be a data and technology provider. I think what I was pleased to see is we had a lot of our customers coming to us saying, and we were actually reaching out to them practically saying, how can we help? What can we do? Whether it was, when nurse practitioners and PAs were able to write orders, we were going into the data and sending them a list of people that they could reach out to and call. We were helping them come up with marketing campaigns. Some of our largest clients called and said, can you do some training, specialized training for our marketers and our organization on how should we think about marketing to and reaching out to referral sources during this pandemic, empathy training. So it was encouraging to see that they were looking to us as more than just a technology provider, but more of a partner to help them navigate this. So I think that was one of the best things that I saw out of all of this is it's more than software, it's more than data, it's a true partnership. And it goes back to what Rachel said, when we're in this industry, we're in this industry, whether we're doing financial services or technology, we're in it. So I think that was what was most encouraging to me is that people were leaning in and that we really did come together as a community to try to help one another through this. We have seen a lot of success stories. And I think the one thing that we're focused on right now is working with our agencies and our clients to build out strategies as we continue to navigate COVID and we continue to learn, like, what is the new norm going to look like with COVID, with PDG, and just the industry as a whole. Working with them to make sure that we have strategies in place, that we are updating and improving our platform to help them with virtual calls, whether it's new call categories, whether or not we're bringing data forward that helps them more effectively and efficiently identify new and additional referral sources that they might need to help. But it's really just the collaboration and the partnership that has been most encouraging to me and that I've seen as a differentiator.
So Rachel, we need to hear something positive. What kind of success stories, what techniques, what strategies are helping your most successful clients?
Well, we were able to, prior to COVID hitting, develop a proprietary technology, a proprietary database for all of our customers. And the wealth of reporting that we can get out of that database has been incredibly helpful throughout, obviously through PDGM, but not just through PDGM. We were able to calculate for LUPAs. We know exactly what the visit utilizations are to avoid those visits for them, to make sure that they get the proper reimbursement. So I think technology and the use of technology throughout this time has helped us be incredibly successful, not just us as an organization, but the agencies that we partner with, being able to help them, since they're the ones out there on the front lines, getting dirty and doing the work on day in and day out basis. So being able to help them has been incredibly encouraging and fulfilling, satisfying.
So you would agree with John that knowing your data, using your data, relying and believing your data is the key to deciding your next operational step.
Absolutely, 100%, without a doubt.
You know what we have to do now? We have to get you all to look into the future. I've tried to be concrete, and I have tried to have you talking about rules and regulations and technologies. But if I could get each one of you to weigh in from the heart, what is your hope for the future of home health and hospice? Are you optimistic? Bobby, you're the one who's most at risk. If you're not, what do you think? What do you feel?
Yeah. Well, as you know, Tim, I've been an advocate and a cheerleader for this industry for almost 25 years now, and but I'm living it on the provider side right now, and I am absolutely more convinced than ever that home care, is a very significant part of healthcare in this country. I think as bad as this pandemic has been and is, I think it's elevated our value to this healthcare delivery in our country, and I think some of the things that we're doing as an individual group of providers, and I believe many of my other cohorts in this industry are doing, is they're stepping their game up. They are investing in technology. They're using the technology. I mean, how many times have we said most of the people out there are using 20% of whatever technology they have? There's 80% of it they don't even know about. And now's the time to reach out and learn that, use it, leverage it. We went down 45% on our patient census at the worst of this thing in April on home health. Hospice wasn't, it was pretty flat. Private services we actually grew that 50%. But in the home health part of our company, that came back to 35% down in May. June, we're 25% down, but our margins returned to where they were pre-COVID, even though our census was 25% down in June. So we're, I'm just convinced we're doing the right things, and the future of this industry, I believe, rests in the hands of the providers and the technology and outsourced services providers, so that we can step our game up and be ready the next time that this happens, God forbid.
Well, as everyone who has been with us for this hour knows, there are 6 people on the screen here who absolutely believe that the more you spend on home health, the less you spend on healthcare overall. We're not sure that MedPAC and CMS believe that. And so what, John, you were saying before about putting in your comments whenever there's a proposed rule to finally get that message through to the rule makers is probably the most important thing we can be doing. That's why I was happy to hear one of you say that a membership in associations, state and national associations, is on the rise. People are realizing, hey, we need to work together. We need the help. So, John, while you talk about your hope for the future, I wonder if you could repeat how people can weigh in on the latest proposed rule. I read your blog, and your recommendations for the kind of comments that CMS needs to hear, I thought was brilliant. And so I wonder if it's okay with Megan and Healthcare Partners if you go ahead and plug that again, because I think it's worth a read.
Yeah, sure. And if there's anything that'll be going out to, the attendees of this, we can put in a link to that so they can read the blog. And basically is that every time there's a rule that comes out, as there is for 2021, we have an opportunity to submit comments on that rule. And the primary comment that I was recommending that everybody in the industry do, I'd love to see thousands and thousands, just with this one issue, has to do with telehealth, because CMS is proposing to allow telehealth to become an allowable administrative type cost, where historically it has always been a non-allowable cost. But I'm saying, since they opened the door to allow us to comment on telehealth, let's try to push it a step further and try to make the comment requesting that telehealth visits in home health be treated as allowable chargeable visits, just like they are treated for doctors, hospitals, and outpatient physical therapy clinics. Treat us the same way. And yeah, so I'd love to see that. I am very bullish on home health, extremely bullish on home health. I think that there's going to be a little pain before, there's going to be a little darkness before the dawn. I think there's going to be some closures like there was with IPS when we transitioned into PPS. A lot of people, for some reason, think that it was because of PPS that we had the closings. And it's like, no, it was all because of IPS. People just didn't make enough money yet in PPS to survive it. I think that there's going to be closures now too because of PDGM. I think that was going to happen regardless. I think the COVID is going to maybe accelerate that even a little bit more because people aren't going to change. People don't want to adapt. And to me, that's always just befuddled me because in life, just like in home health, I've been in home health since '92. Okay, the only constant that has existed in home health since that period of time, and I'm sure it predates me, is change. Okay, so why try to fight the change? Okay, but that being said, I think the future looks great for home health. Okay, you look at more and more individuals, as Bobby was alluding to, more and more individuals want to receive care at home. They feel safer at home, and I think the pandemic is only reinforcing that to an even greater degree than what it ever has been in the past. And the Medicare population is going to continue to grow for the next 20 plus years. So you have both of those coming together. That bodes well for us in home health.
We baby boomers are turning 74 this year, so I know exactly what you're talking about. And unfortunately, we're a little bit over time, so I want to turn it back over to Megan. But first, thank all of you for these brilliant insights. And John, how do they find your blog again?
It's at www.ifs4homehealth.com.
And I'm sure Megan is going to provide a way that we can get in touch with Health Rev Partners and Playmaker Health as well. So thank you all very much. I learned a lot today. I hope all of you who've been following us did too. I'm Tim Rowan. Megan, it's all yours.
Very good. Well, thank you all so much. I would like to extend our appreciation to today's panelists and to you, Tim, for sharing your time and expertise. We learned a lot of good stuff today. We will be sending out an email with the recording, as I stated earlier, and information if you would like to reach out to John, Holly, Chip, or Bobby or Rachel. We hope that you've enjoyed the discussion today. And if you did, please don't forget to register for our last forum in the series. It's on July 23rd, and we're going to be talking about agency leadership and overall operations, risks and opportunities that come along with COVID-19. We've got a great group of panelists lined up for that one as well, so you won't want to miss it. To register, just go to www.healthrevpartners.com/webinars. Once you leave today's webinar, you will see a survey pop up. Please fill out the survey to give us your feedback. You can also use the survey to let us know if you'd like to learn more about Health Rev Partners or any of the other panelists that have spoken today. So on behalf of Health Rev Partners, Tim Rowan, and our esteemed group of panelists, thank you so much for joining us today and have a great afternoon.
Yes.